All right, hey everyone, let's get started. We are going to do conference today called Tachycardic Nights because I couldn't think of a better title sitting in my office this morning. So we've got 3 cases, one's a little longer, 2 are shorter, and they all sort of either made me tachycardic or the patient is tachycardic. And all 3 of these people have been admitted to the VA in the last 24 hours, so sort of fresh cases. So with that, I'll defer to the room. Which door do you guys want to go through first? Dom goes with door number 3. That's the most unified I've ever seen a room. Everyone said door number 3. So door number 3 is going to be our case, which is slightly longer. So this person presents to an outside COVID testing area outside of our ED. They've got generalized weakness. The heart rate was between 31 to 70, SATs 85 to 92. Episode of chest pain this morning to center of chest, non-radiating, 2 out of 10. No current chest pain, some intermittent nausea. They use 1 liter at night, but have been using more during the day recently. Denies fever, cough. Last COVID vaccine was 2/14. I will go ahead and say this is not the person in the ICU who has COVID after the vaccine. I wouldn't do that. Afebrile, heart rate is 65, blood pressure 81/56, 87% on ambient air. So what's going through your guys' mind right now, sort of hearing this question stem or chief complaint stem? Great. So Peter is pretty close to being out on his own, and he's like, "I've seen enough. Let's admit." That ends up happening, but I think that's what Peter's getting at is like that sick, not sick dichotomy right off the bat. And this gentleman sounds sick, and so going to be admitted. Okay. So let's keep working through this case here. So here's his HPI, a nicely written HPI by one of our residents, and I'm just going to highlight the pertinent stuff as we go through. So pretty good cardiac history here, multiple stents, COPD, PAD. So he's got stents in his heart, stents in his legs, has a history of an upper GI bleed. That's 1 year ago, coming in with weakness and shortness of breath. Symptoms worsening over the past 2 weeks, but worsened acutely 2 days ago. Feels very weak and fatigued. He says normally he can't walk very far, but he feels worse than Saturday. He says he's now unable to walk from his kitchen to his living room. And he says that he also has a poor appetite. Finally, dizziness with standing. So that HPI, in addition to the chief complaint, Peter, any additional thoughts besides just the word admit?
I mean, the history of the upper GI bleed is all of this makes me more concerned that we're having a possibly like unifying hypovolemia picture and likely hemorrhagic leading to both shortness of breath as well as orthostatic and could be worsening hypertension.
I like that.
That's my thought.
Nice. So Peter saw that history of upper GI bleeding, got really concerned about hypovolemia and hemorrhage. So a can't miss diagnosis in that question stem. Is this man acutely bleeding? Any other thoughts from the room on this HPI?
A little worried. It might be like an anginal equivalent. What he's talking about is like dyspnea, not feeling well, and now he's a little bradycardic. So really got to make sure they're not having like a RCA issue.
Great, I like that, Dan. So RCA issue, is this an anginal equivalent? And then Anita says, can potentially fit into 3 of the 4 dyspnea boxes, so heart, lungs, and blood. That's great. Yeah, so I think really good points here that we're sort of narrowing in on the dyspnea, but we can't rule out more concerning things, which is sort of the point of this HPI. So from here, let me give you guys a little bit of a physical exam. So your physical exam, no acute distress, well appearing. His head looks okay. It's the right shape. We'll say he is regular rate and rhythm, no murmurs. He has some bilateral expiratory wheezes, decreased breath sounds at the bases, and he's got no cyanosis or edema.
JVD plus 10.
He has JVD plus 10. Nice work. Nice work. I knew that was there. I was testing all of you. Yeah, he's got JVD plus 10. So he's got a lot of JVD, but no peripheral edema. Okay, with this exam and that history, I'll give you guys the choice. Do you want labs or a EKG or a chest X-ray first? And Dom, why do you want a chest X-ray first?
Decreased breath sounds, very wheezing,
I'm kind of going for almost like congestive heart failure exacerbation.
Great. So Dom saw this, he saw this, and he said maybe this is CHF, which is a really, really nice thought. Okay, so let's get that chest X-ray. So here is your chest X-ray. I'll give you guys about 30 seconds or so to take a read of this, and then we will walk through it. All right. Does anyone, any intern want to volunteer in the room to give a focused read of this? We'll work our way up the ladder. We'll go second years. Anyone want to give a focused read of this?
I can read it.
Dom, coming to the rescue, sitting directly in front of me, so it's weird, but crushing it.
I mean, straight away when I look at it, it's like in the lung fields, there's definitely like cephalization of like the vessels there, the pulmonary vasculature, he has pretty flat diaphragm. Those are kind of big things. Obviously, he's had heart surgery, so you can see kind of the sutures or the steel there. That kind of heart surgery kind of throws off the anatomy as well. It looks like also his PE arteries seem like they're kind of dilated on the right side.
Perfect. That's a great read. So if you were going to put like your finger on a diagnosis or give your final like impression here, what would your impression of this be?
Like pulmonary hypertension, CHF exacerbation.
Great. I like that. So narrowing in on like volume overload conditions. Dr. Chan is on with us today. Dr. Chan, do you have anything to add for this chest X-ray?
Yeah, I don't see any curly B lines. Those are, horizontal lines at the costophrenic angle that goes out all the way out to the periphery. But I agree with everything that was just said. I just wonder at the lower mediastinum, is there like a circular structure there?
There is indeed a circular structure at the lower mediastinum. Dr. Chan, what do you make of that circular structure at the lower mediastinum?
I guess it could be a hernia. It could be a paraesophageal hernia. A lateral could be helpful, but this is obviously a portable. You wonder about vasculature too, like an aneurysm or something, but I'm having trouble.
That's great. Dr. Chan, one of our experts, called that perfectly. That is a paraesophageal hernia, which we'll look at better on a CT scan in the future, spoiler, but there is a hernia there as well. And so if you can see the hernia outline here, sort of tracing around. Okay, so that's what his chest X-ray is. So table this in your mind. Someone has quite the ringtone. Here are his labs. I have not highlighted anything in red today, so I'm going to make you all do a little bit of extra mental legwork. But someone please just call out what are the abnormal labs here. Hemoglobin's a little low. Troponin. Is the D-dimer high? Dimer is high. So a D-dimer close to 1,000 is AB normal. Great. So this man has an elevated D-dimer, an elevated proBNP, an elevated trope, this chest X-ray. Is there any way he gets out of the ED without getting a CTPE? No. Absolutely not. So, absolutely not. So here is his mediastinal and vascular window. I'm going to scroll through this one time. Did anyone see a PE? It was really fast. It was indeed. All right, we'll play this back.
Was that the entire?
Ignore the circle. I don't know what it's showing. False negative circle sign. All right, so I'll tell you guys, there's no large PE on those windows, but what you do see, interesting stuff. So this is the hernia Dr. Chan was talking about. So right here in the middle of the screen, this thing right here is that paraesophageal hernia. And so that's why you can see it behind the heart. And then the other thing you notice is that he has a little bit of right here, if we pause it, you can see that he's got some contrast sort of extravasating or pushing backwards into his hepatic veins. And so he's got reflux of contrast into the liver from a CTPE, but no clear PE in at least his large pulmonary vessels. And then I'll show you the lung windows now. Not a sticky note. And again, call out whatever abnormalities you guys see as we go. Play that one more time. Great, so Anita says right-sided pleural effusion, which is correct. Nice, so he's got some ground glass on the right side as well. Sort of all over, but definitely ground glass on the right side. And that's great. So small pleural effusion, ground glass, and then the other thing that we see here, which we didn't really see on the chest x-rays, you start to see curly B lines. So those things right there are curly B lines on a CT, right? So those sort of perpendicular lines touching the periphery. And if you go back towards the top, you can see that he's got some like septal thickening. So a lot of the septum here are thickened. So what is the actual read here? So his actual CT impression shows that he does indeed have suspected non-occlusive PE in the segmental and several subsegmental PAs. He's got a backdrop of central lobular emphysema, patchy ground glass, small right pleural effusion, and some cardiomegaly, and their read is possible CHF and PE. So nice job, Anita, nice job, Room. You guys essentially called that perfectly. So my question to all of you now, so I want you to take like 30 seconds at your table, is come up with what you think what is driving this man's shortness of breath? Is it a PE, is it COPD, or is it CHF?
They didn't come in all that right when they were pulmonary. I'm all about this.
I know you are. I know you are. Actually, Luke, sit here. Sit here. All right, let's come back here. So just for the room, what do you guys think is the hey everyone, let's come back. What do you guys think is the leading cause of his symptoms? What do you guys think is the leading cause of his symptoms? He also has a trope. He does indeed have a trope. So Leela, what do you haven't seen an EKG yet? Great. So here's your EKG. We'll pretend that we don't have a prior because it's not in CPRS. And Leela, what is the striking abnormality on this EKG?
It looks like he has some SD depression, Hernia, elevation to V1, and whatever is the top relation. Is that V1?
Yeah, that's V1. Early one.
So kind of some localizing ST depressions, I'd say, are they're mostly diffuse under V1.
Great. So sort of like some diffuse ST depressions, maybe localizing with that positive trope concerning for possible ACS as well. So this man has ACS, has some sort of ACS criteria, has a PE, has probable CHF with his heart history, and also has COPD. So is there any way for us to, like, how would you prioritize treating this man right now? Get some aspirin in him. Okay. What else? Or we just say an aspirin monotherapy? Hit all the bases.
Cardiology folks.
Great. Call cardiology, aspirin, heparin drip.
Yeah, heparin drip, 2 birds, 1 stone.
2 birds, 1 stone. I like it.
He's chest pain free right now.
He is chest pain free. Great. So that is what the team did overnight when they were admitting. They called cardiology. They gave him an aspirin. They started him on a heparin drip. And cardiology said possibly cath him in the morning. And we will kind of go from there. So this gentleman is still admitted. And so right now it's sort of, sure.
All right, so if we're thinking about ACS, pharmacology, you guys throwing out a lot of stuff. So Dan, you might have to recapitulate this for the rest of the folks. But if you can only choose one thing from the mode of BASH, morphine, oxygen, nitro, aspirin, idostatin, heparin drip, ACE inhibitors, all that stuff, what would you guys choose? What is the most important for your patient? ACS.
I'm just a simple country doctor. I choose
Aspirin, it's easy, it's out there. Who likes heparin? No heparin? Statins, beta blockers,
Oxygen for sure.
oxygen, morphine, don't go morphine. Morphine. Excellent. So the most common answer I get is heparin. This is incorrect. So if you have a patient with ACS or unstable angina, we know from the VA co-op trial back 1983, great year, that aspirin versus usual care in unstable angina reduces mortality. Number needed to treat is on the order of 14 to prevent 1 death. So number needed to treat an ACS for heparin drip is on the order of, it's in the 1 to 200. So this really does matter because you guys all know when you admit patients and you talk to the ER, one of the questions I ask them is, did they get their 324 aspirin sheet? And I'd say about a third of the time when they would call me, they would be like, well, I don't know, or maybe they did, or maybe they got it in the ambulance, just repeat it. If there's a question. So that's just always my sort of public service announcement. ACS, aspirin.
Great. Thanks, Dr. Berry. Very last thing here. When you guys are writing your hashtags in your note, does this man have a submassive PE?
Does he have a, he doesn't have a P? Oh, right. Does he have a
He does have some subsegmental PEs.
Wasn't his blood pressure low?
Blood pressure was low,
Well, what was it?
81/50.
Do we have a baseline blood pressure?
It's about the same. So the thing you guys are all getting at, and let's just sort of quickly go through this real quick. PE, right? We talk about this a lot. Acute PE is what we really talk about. And so, right, the reason Leela was asking what his baseline is because she's trying to figure out this is massive or submassive. And so, Leela, what would cause you to say this is massive?
I think it's like either his absolute blood pressure or the difference from his baseline. It's like, was it 40 points systolic?
Yeah. So if your systolic drops by greater than 40, that meets criteria, or if you're in shock, or if you arrest. Otherwise, if you've got RV dysfunction, you meet this middle box. And that's a positive trope, positive BNP. And so Peter is right. Definitionally, this man meets criteria for an acute submassive PE because we don't have any other history. Last month, we had an M&M where we talked about COPD and PE. And so just a reminder that it's a hard diagnosis to make in these patients. And so keeping your index of suspicion high for a PE, that may not necessarily be what's driving this man's care, but certainly isn't helping his underlying cardiac problems.
Is contrast reflex sufficient to go right ventricular dysfunction, or do you need like DSP?
Yeah, great. So what Evan asked is reflex of contrast sufficient to cause RV dysfunction? And yes, it is. So it is the CT criteria. So on your CT, you can have, so like if we go back up to this guy's CT and we stop right here, you see that his RV is smaller than his LV. So if his RV was larger than his LV, that would be one criteria. And then reflex of contrast as well gets criteria on a CT. And so he meets criteria for submassive. All right. So this was the one patient who's not tachycardic. So back to the front, we've X'd out door 3. It's sort of multifactorial ACS, CHF, TBD on how that case ends. All right. Door 1 or door 2? These are the shorter cases. Door 1, I like it. Patient reports onset of AFib at 9 o'clock yesterday. States metoprolol was ineffective. He has mild space, indent, next line, left shoulder pain. He is afebrile. Heart rate is 135, 97/60, 94% on ambient air. Do we take him at his word and just be like, yep, for sure AFib? Don't need the EKG. We do not. So we get an EKG on this gentleman, and here's what it shows. So take about 30 seconds, 45 seconds at your tables, and then we'll come back and read it. All right, Katie, you were overheard what you were saying and you were crushing it. So Katie, what are we looking at on the EKG here?
So from here, it does look like there's flutter waves. Sometimes it's hard for me to tell towards AFib versus flutter, especially when it's irregular. So, I probably, if I had it in front of me, marked out the P waves to see if they're even and equal. And probably this is flutter with variable conduction because the QRSs are irregular.
Yeah, that was an excellent explanation of flutter with variable conduction. Strong work. So this is flutter with variable conduction. Katie performed the role of the top of the EKG, and this is correct. So flutter with variable conduction. Does anyone have questions about how Katie got to that end diagnosis there? All right, so flutter with variable conduction. So how are we going to treat this guy? Great, call cardiology. They say we are at home. It's overnight. You guys can do the first part. So Nia says, what are his pressure? So his pressure is 97/60, which is roughly kind of a little close to his baseline. All right, so what you guys do is take 30 seconds at your table and give me a medicine you want to give him, or medicines and doses of those medicines.
You don't want to drop the pressure. But that's vaccine, so she can do 150 over 10 minutes.
If he's 60 over 30, yeah.
First question.
Oh, yeah, she's KD.
This is the All right, guys, let's come back. Peter, you asked a couple of questions to your group. What other information did you want to know that I have not told you yet?
The first thing I was thinking about was, is he anticoagulated at home and has he been taking his medicine? Like based on the rather sure stage BI, it sounds like he is known SVT, so probably is on something. And then, so most likely I want to have
Great. So I'll say that he is not on anticoagulation. He has a known diagnosis, but hasn't been on it for a few months because his CHADS FAST was 0 and he was not symptomatic. But I will give you that a heparin drip can be started in the short term. All right. So what do you guys want to treat him with? How are we going to fix his acute rate issue?
You guys want to point out that the rate on that ECG is actually not the documented 135. It looks like, you know, it's really hard to guess, but I would say it's somewhere like in the 80s and 90s. So based on his rates and his stability, you know, falling back to what we know about rate control strategy, targeting a more liberal rate control strategy than a more aggressive or like a more conservative rate control strategy. We may, you know, not need to dose this guy with a whole bunch of meds or do a whole lot overnight if he's looking okay.
I will say that is not what happened, but Dr. Rudofker has valid points that I completely agree with. So what do you guys want to treat him with? Let's pretend that we actually think his rate is 130 or 150.
And it was shortly after.
And it was shortly thereafter.
Everybody's thinking that.
Just you got to say it. There you go. We're all thinking it. We're all thinking it. That was not a trick question. So right, a Faber flutter with RVR. Right, we go down either the beta blocker or the calcium channel blocker pathway. I personally have always been more comfortable with the beta blocker pathway, and like Dan pointed out, the beta blocker pathway is metoprolol. And what's our dose, Dan? And how many times can we give it? And what's our lockout interval there? 5 minutes. So personal lockout, you got to wait 5 minutes before you give it again. You can do it 3 times. Let's say that you wanted to put them on a drip in the beta blocker pathway. What drip would you have available?
Dilt.
That was so confident. It's incorrect. I like it. We'll get to that, Rachel. So Esmolol. So Esmolol, right? You get it. It's a bolus. Then you get plus or minus. The bolus is plus or minus. Then you get the infusion. And so why might you choose Esmolol? Yeah, great. So it's short acting. So the half-life is like roughly like 6 to 10 minutes. And so if you're not sure if they're going to tolerate a beta blocker, you can put them on an Esmolol drip and see right away whether or not that beta blocker is going to be good for them. Calcium channel blockers, what are our options?
Oh, you didn't say calcium.
You're ready. Rachel, your time in the sun. What is it?
Well, stills.
Great. So Rachel, her time came. She said diltiazem. Perfect. And what are our doses for diltiazem?
15?
Got to vote for 15.
5 to 15, or it's like a rate.
Weight-based. Katie said it's weight-based. She's kind of squinting at the same time. Cool. So let's talk about, so where do these, I actually had no idea where the doses came from. We'll talk about what the doses are in a second, but in a shout out to Andy Berry, we're going to go back to the late 80s, 90s. So there's this trial that came out way back in 1989 in the American Journal of Cardiology. And they basically did an RCT on diltiazem for acute rate control for AFib and A-flutter. You had to have a ventricular rate greater than 120, a systolic blood pressure above 90, which this guy has, and no severe heart failure. And the first dose they did was 0.25 mg per kg. So Katie was correct. It was weight-based. If you didn't respond in 15 minutes, they did another dose at 0.35 mg per kg. So that roughly comes out to like 10 to 20 and then 20 to 25. And so you escalate the second dose if they don't respond. And so overall, what do you guys think they showed between diltiazem and placebo? Yeah, right. We wouldn't have been doing this for close to 30 years if it didn't work. So 93% of people responded to diltiazem. And then, which is sort of interesting, like 12% responded to placebo, sort of showing us that like probably 12% will just spontaneously convert themselves. And then the study was interesting because if you didn't respond to placebo, they gave you diltiazem and they got to like a 97% response rate. And so proving that diltiazem works, and that's why we still use it. So your starting dose here is going to be basically 10 to 20. If that doesn't work, do 20 to 25. And then you put them on an infusion. So very rarely do people get out of the ED without getting a diltiazem drip after getting their initial boluses, because you've sort of loaded them and then you would continue them on a maintenance dose. And that dose is 5 to 15. Is there another medicine we can use, which is an electrolyte that could also help us here? Magnesium. Who said that? I love it, Evan. Evan, why can you use magnesium here as well? Oh, amazing. So I'm going to add this. You guys should add this weapon to your like AFib, A-flutter arsenal. So magnesium, like Evan said, is a calcium channel blocker. So it blocks your L-type calcium channel. And believe it or not, there is an RCT for everything. So this study from, it's called the low mag high trial. And basically what they did was they took people and they said, if you come into the ED with AFib with RVR, we're either going to give you placebo, we're going to give you mag 4.5 grams, or we're going to give you like an OB dose of 9 grams. And we're going to see what happens to your rates in addition to your regular other agents, DIG, diltiazem, and metoprolol at 24 hours. So interesting study, because what they showed was that at 24 hours, the high dose and the low dose magnesium groups were equivalent and better than placebo. And so all of these patients, their mag was a little bit low when they came into the ED, but this trial sort of provides evidence that if you need an additional rate control agent and they have a low mag, you could give them a magnesium bolus and see if it helps, in addition to your diltiazem, your metoprolol, or your esmolol. Yeah, so this was just a single dose. It was a single 4.5 dose or a 9 gram dose. So
It also looks like it basically took 4 hours to take that.
yeah, great point. So it takes about an hour for this much magnesium to go in. And so it takes about 4 hours before you see this effect. But then it seems that from that point on, you're less likely to go back into whatever rhythm you have. And so my own personal practice, how I've used this, if my patients have like an alcohol use disorder, or I know for sure they have a low mag, then I start giving them mag right when I admit them, if it's an AFib with RVR admission. You're not gonna hurt them. Don't be scared of that much mag. OB does infinitely more. And as far as I know, everyone's fine. All right, so this guy gets his agents, he gets converted out of it. And Eric, what is the next step then for someone with flutter?
Yeah, I just want to say, I think we all failed step 1, which is what's the EF? So neither of these pathways we would want to go down in someone with a depressed EF. These are both negative inotropes and can cause the patient to go into cardiogenic shock. So fortunately, this patient had an echo like 3 months prior that showed an EF of 55%. So we did not, so we felt comfortable kind of loading him up with beta blocker, then calcium channel blocker, then beta blocker, and then back to calcium channel blocker. And then what do we do? So now he's rate controlled in atrial flutter on a diltiazem drip. Now what? What are options? Discharge, right? That's yeah, one, like, all right, achieve rate control. You're feeling okay, great.
Rhythm control, consider
Cardioversion is another. And then ablation. And Anita saying ambio. So ambio would be can be used as a rhythm control agent. Can also be used as rate control. May not be necessary if we've achieved good rate control. We can't discharge them on a diltiazem drip, right? So first we'd have to convert that to orals. But the determination of which of these kind of depends on what's driving the atrial flutter, right? So I think we have a tendency to forget to think about why this person with known flutter in the past is now in flutter again. And one question is, did he achieve sinus rhythm in the interim? Because if he did, then you really want to know like what triggered this current episode. So taking a really good history, going through all the things that you typically think of as causing atrial flutter, infection, thyroid issues, PE, sleep apnea, hypertension, worsening heart failure. In this case, he had no heart failure symptom, no heart failure sign, so we didn't go back and do that. We really didn't find anything that we thought would set this person's atrial flutter off. So we were planning on getting him out of atrial flutter with a potential ablation until Do you have more data for the rest of the story, or is this it?
I don't have more data.
Yeah, so he last night had a 5-second pause and then a series of junctional beats and restored to sinus bradycardia.
All right.
So now you're thinking, great, our drugs actually worked, which they rarely do in atrial flutter. We can now send him home and get this definitive ablation, which is 80 or 90-some% effective as an outpatient later on, except he had like 20 seconds of actual VTAC overnight, which people with otherwise normal hearts don't have. So we'll be repeating his echo today to look for any change in his EF or any change in any other like structural change that might clue us into why he has all these abnormal rhythms for an otherwise healthy 50-year-old.
Cool. Thank you, Eric.
Is he on oral diltiazem now?
He's now on oral diltiazem. Yep.
Great. So Eric brings up a good point, right? For the sake of the conference, I didn't give you guys more history, but we knew he had a normal EF before we pushed the medications. Interesting conclusion to that.
Yeah.
Diltiazem works. And then Dr. Chan's point, which I want to hit on real quick, he said, don't push magnesium, it causes hypotension. And right, the mechanism, it's a calcium channel blocker. And so that's why we give magnesium over an hour, which I actually never thought about till now. So thank you, Dr. Chan. All right, so case number 1 was a person who had AFib or a flutter. I hope I didn't give away what number 2 is. So this is number 2, final case, pretty short. Having first episode of COPD in early April, for which he went to the VA ER, prescribed a course of antibiotics and an albuterol inhaler, followed up in rapid access clinic on 4/13, where he didn't see Corey, but I'm sure Corey was aware. He has since finished his course of antibiotics and still has the inhaler, but he still has trouble breathing. He is going to get an EKG in RAC clinic, and here it is. It's take about 30 seconds, and I want to hear what this EKG is. All right.
This is a good ECG.
Yeah. We'll see. Who has not participated yet? Anyone want to volunteer to read this? All right. Let's go with, man, I don't even know. Peter, what are you looking at?
At first blush, I thought it's probably AFib. It's some kind of SVT, right? And I thought maybe it's AFib because it does not look like it's perfectly regular, and I cannot see obvious T waves. If I look hard enough, maybe I'm seeing T waves somewhere, but I'm not sure.
That's great. This is indeed AFib with RVR, but it is subtle. And the sort of giveaway is this interval right here. If you sort of look at that interval and then start to compare the other intervals, like this one, you see that they are varying. And so Peter did a nice job. So SVT, it's narrow, it's irregular. This is AFib with RVR. So why is this gentleman in AFib with RVR? What are like the history questions you're going to ask him in RAC clinic? Just got diagnosed with COPD, maybe hasn't felt so much better.
Heart failure question.
Heart failure questions, I like it. ACS questions. Thyroid stuff. I like it. So alcohol, drugs, thyroid, heart. You guys are going to hammer those questions and get some history here. So here's his HPI. Seen him rat clinic. He's now in our ED. 1.5 weeks of increasing dyspnea, congestion, cough. Said he didn't feel better. He feels fine. Didn't have any complaints. Mild palpitations the last couple days. And then he gets into this part. He says he's been using his albuterol ipratropium 2 to 3 times per day, and he's been just sucking down that inhaler overnight as well. However, interestingly enough, he's still able to do spin classes, which is not something you hear a lot at the VA. He is bronchodilated, and he's still able to hike. So he's doing okay. All right, so how would you guys treat this gentleman? We do not know we don't know if he has heart failure.
Can we get an exam?
Yeah, you can get an exam. Great answer, Kate. You can indeed get an exam. Here's his exam. Spoilers, this was after the intervention was delivered. This was our residence exam, not the RAC ED or record. All right, so pretty normal exam. And so at that point, right, just to hammer home, which pathway are we going to go down at this point? Do you guys want to do beta blockers or calcium channel blockers? Beta blockers, I like it. So this guy gets beta blockers and they don't work. What do we do next? His blood pressure is 181/89. So what do you do if one of these pathways doesn't work? Yeah, you just switch to the other pathway. So if you get blocked in the first pathway, you just switch to the other pathway. As long as they don't have heart failure, that's generally an okay strategy. And so they switch to the other pathway, they put him on a DIL trip, and this gentleman sort of spontaneously converts out of AFib within about 4 hours. The question is though, this guy right here coming in with COPD and these symptoms, do you need to get a D-dimer? Do you need to get a CTPE on him? Or are we comfortable enough saying it's the inhalers? So this guy is on one of the teams right now, and I'll tell you that he has not gotten a CTP, and I think it's interesting because we talked about this last week at M&M, we talked about it today, and I think it sort of highlights just how difficult this diagnosis is. You've got a pretty good mechanistic reason. He's getting a lot of beta agonism, and if he's feeling better, you may not have to go down that CTPE pathway.
What's his pretest probability of PE and IBS? That's a trick question. So what goes into the dichotomized well for PE? What are our questions? What are we asking? One question everybody hates, right? Do you think this is PE or do they have another diagnosis that leads you to their symptoms, right? So if you answer yes to PE is my most likely diagnosis, you should probably be scanning them, which is why I get 3 points for that. What are the other questions? What's it? What else?
Cancer.
Malignancy, right? Cancer, yeah, what else?
Immobility, surgery, I guess.
So immobility, and if you guys actually read into the well score, it's pretty profound immobility. So this isn't, hey, Mr. Jones is in the hospital later, but most of the day and walks around to the bathroom. This is like basically the equivalent of 3 days of strict bed rest. So post-surgical patients and people are very mobile. And then there's one more kind of further one. Clinical signs and symptoms of DVT. Okay, so he has none of those questions, and we have an answer, we think, why this guy has the symptoms he does. So if you're a purist, you could go by the dichotomous well score and say, you know what, this guy's got low risk for PE. Reasonable not to scan him. I'll tell you, you did get a dimer downstairs, didn't you?
No, got through the ED without a dimer. But I think I think Dr. Barry brings up an excellent point, which is, right, we know PE is a comorbidity that people with COPD suffer, and we don't necessarily have to scan everyone, but you need to probably think about it for every single person that comes in with dyspnea and COPD. And so maybe that's getting a dimer on people if you have a higher index of suspicion. Maybe it's just thinking about it. But I think this case highlights that you should still consider it in each of your COPD patients.
So a lot of these scorings are done on the ED. I have trouble remembering what's validated for like inpatient. If you could use them and like I have trouble with that.
Yeah, so you're asking is like the well score validated for
Yeah, 'cause
inpatients?
I think a lot of times it's for ED patients, if I'm not mistaken, so.
Of course, for everyone. So that is your pretest probability of PE, right? So the one that like, I don't know your names, right? But she yelled out like heart rate. So there's things called the Perk criteria. This is more of an ER deal, right? So the Perk criteria, the PE rule out criteria, are a whole compendium of questions that ask you things like, what is their age? What is their heart rate? What is their SpO2? There are a number of them. And if you are answer no to all of those, you can perk someone out. And effectively, you rule out PE. So I think you can use, I've used the Perk criteria in patient as well, right? But it's not something we encounter often. And if you do get a dimer, so let's say this guy's dimer is 437. Then we have to think a little bit more about all these dimer corrections that you can do. There's an age-adjusted dimer. There's a years criteria that came out. So, so you guys can look into this. So I think that there's more thought that goes into this than often our ER colleagues put into it, which is, oh, yeah, maybe this could be PE. Let's just try to scan this person. So those are the ways that I sort of frame it. And to answer Kate's question, you can do all this in patient. It doesn't matter if we are ambulatory or here. So.
Cool. Well, that's all I got. Just a reminder. So we talked about the first case. It was a ACS, CAHF, COPD, smorgasbord, had a good chest x-ray. This gentleman has cardiac eval ongoing, I believe. Number two, we just talked about was PE, thinking about it, but likely AFib exacerbation in the setting of a lot of beta agonism. And then finally, we went through that sort of classic pathway for fib flutter, making sure they're not in heart failure, and then deciding if you want a beta blocker or calcium channel blocker, and sort of what our evidence is for both those strategies. And that's it. Thanks, guys.
Yes.